Hello, fellow zebra hunters. This is Diagnostic Atypia. Please remember, the content of this podcast is meant strictly and exclusively for the purpose of education and entertainment. The information discussed is not a substitute for your own clinical judgment. All opinions expressed on this podcast are exclusively those of the hosts and do not reflect the views of our employers or other affiliated entities. All cases discussed are HIPAA compliant, with key identifying details changed. Hello, everybody. This is Mike Arcieri, and I am here with Andrew, of course, as always, and really excited to welcome one of my best friends, friends since childhood. Our dads were friends together in residency. This is Dr. Nick Salter. Nick is a family medicine doctor who actually just started as an attending earlier this year. And I just so excited to have him on here. And Nick, welcome. Tell us a little bit about yourself. Tell us about where you practice currently.
Yeah, Mike, thanks so much for having me on. I have known Mike since probably we were both cognizant of each other's awareness on the scale of days to months. And for those of you who don't know, in addition to being brilliant, Michael Arcieri is an amazing human and one of my favorite people. And when he told me about Diagnostic Atypia, I was like, of course, as a good friend, I will check it out. And then I went from being a Michael Arcieri fan to being a Diagnostic Atypia and a Dr. Andrew Sanchez fan as well. I'm tuning in for every episode. I love it. You guys have got me hooked. And the amount of times I could probably count, amount of times on two hands, Andrew, that you've blown my mind. I specifically remember I can't remember if it was the beta HCG that was acting as like a hyperthyroidism in one of those cases. Sorry, spoiler alert. I probably should have said that. But that absolutely blew my mind. And anyways, I've had a blast listening. But I am originally from York, Pennsylvania. I just finished up my family med residency in Charleston, South Carolina. And I've had the pleasure of signing back on in York. So my position is I see my own patients 3 out of the 5 days a week, and then I precept for the other 2 days, and then I'm on the family medicine inpatient rotation every other month as the attending. So I get a nice little hybrid, and I'm really enjoying it, and I'm happy to be here.
That's awesome, Nick. Really happy to have you. Friends of Mike's, friends of the pod, always. That's the rule, listeners. It's an absolute pleasure to have you here. And
Awesome.
yeah, what did you bring for us today?
Yeah, absolutely. So this is a case that I actually got Sunday. It was the basically my last day of being an inpatient, and I had already rounded that morning. But the resident signed out this case to me, and it just kind of there's been a lot of twists and turns, and I'm hoping you guys will enjoy it. So, without further ado, I was called by the residents for an 82-year-old female with a past medical history of osteoporosis, oropharyngeal cancer, status post laryngectomy with a chronic trach, coronary artery disease, hypertension, right renal artery stenosis, type 2 diabetes, and hypothyroidism, who was brought into the ED by EMS for altered mental status and a posterior headache. Patient's husband was concerned that her blood sugar was low, and he gave her a glucose pill. When EMS arrived, her blood sugar was 302, so not low, but her heart rate was in the 20s and 30s. So that is kind of the first aliquot, and I'll kind of leave it to you guys to see what your thoughts are.
Ooh, I love it. Mike, do you want me to start with the first aliquot?
Absolutely, yeah. Take a stab for sure.
Okay, it sounds good. It's kind of hard to know what to latch on to up front here. Certainly, the chief concern it sounds like is encephalopathy, which we can characterize further as the case goes on. But the heart rate is fairly low, and interpreting a heart rate in isolation is very challenging, particularly when the heart rate is on the low side, because many people, including Michael Phelps, have heart rates in the 20s, and they're living just fine. So having the rest of the vital signs is really helpful because if the blood pressure is very, very low, this could represent kind of like a peri-arrest sort of situation where someone is kind of coming in crashing and you kind of have to resuscitate them and figure out what's going on later. Or this could be someone's kind of like chronic bradycardia too. So first thing I want is just like a complete set of vitals with the oxygenation as well as the blood pressure. And I'll just comment separately for kind of rapid diagnosis of encephalopathy in general. I like to scan mnemonic to try and figure out what's going on in terms of life-threatening issues kind of up front. So S is for sugar, which Nick kindly gave us, basically interrogating, is the patient hypoglycemic when they came in and all they need is some dextrose, and then you can solve that issue. Do they need a CT scan of the head to catch acute hemorrhage, acute hydrocephalus? That's really what the CT scan is good for. A stands for ABG, but you can also get a VBG, of course, to look for, is this patient retaining? It doesn't sound like this patient has any sort of history of COPD or hypoventilation of any sorts, but certainly in the unsolved, kind of undifferentiated case up front, we think about getting blood gases just to make sure, and then you can solve that issue. And then N is for Narcan or narcotics. So was this patient on chronic opioids? Is there any chance they just need a little bit of Narcan to get them over the edge? Those are like the four quick checklist items I run through for encephalopathy. We already got partial information on that, and just looking to hear a little bit more on the vitals. But Mike, what crossed your mind?
Love that mnemonic. I think it's sometimes the things like AMS, which you just feel overwhelmed with the differential. It's helpful to just have a schema that you can follow every single time. And it just helps you feel a little bit less confused in those moments. No pun intended. So I think the other thing I agree, we would definitely want to see the vitals because that helps put us in characterization. But I think probably a TSH here as well. I noticed the hypothyroidism diagnosis, and that can give you certainly confusion and bradycardia, mixed edema coma sort of thing. So I think that would be just the other thing, and I imagine we'll get a bunch of other good stuff here too. I agree that meds are going to be hugely important. I feel like half the time it's something we've done to the patient rather than something inherent. So that's been the lesson of my short tenure so far. So yeah, Nick, what else do you have for us?
Yeah, I love it. Great discussion. That scan mnemonic is something that I haven't heard of, but is I think great to think about. As far as the rest of her other vitals, so I'm looking through this ED note, and honestly, I don't see the exact documented vitals, but I can see what they wrote. The maps were initially a little bit less than 65, but then it came up after a little bit of atropine. The atropine got her heart rate to around the 40s. And then they were saying that her maps were consistently greater than 65 after the 40s, I'm sorry, the dose of atropine. As far as her oxygenation, um, she is on that chronic trach. They put a non-rebreather on her trach again. And I don't have an initial O2 sat or any like ABG or VBG that was get obtained, but the sats were maintained greater than 92%. They were saying with a good waveform. So not not the most I would say complete sort of vitals history, but overall fairly stable other than the bradycardia. Um, so the atropine was given and the heart rate was in the 40s. I'm gonna send you guys um, a picture of the EKG
Ooh, I love
that
it.
they got. So give me 1 second here.
And Mike, maybe even while he's sending it, since I started the last one, what would you be looking for on the EKG? Because it sounds like maybe the bradycardia was contributing to the hemodynamics. Maybe it's always hard to say, and he didn't really give us anything else. So I'm just curious. I have some stuff that's kind of crossing my mind, so I'm curious if there's stuff crossing your mind.
Yeah, with bradycardia, tachyarrhythmia, I think the question always originally is this something that's primary primary arrhythmia, right? Do they have heart block and that's why this is the case? Or is this just, profound sinus brady? In that case, I mean, you can have sick sinus syndrome, but usually there's some amount of irregularity to that. If it's truly regular sinus brady, almost always, just like sinus tach, right? You have something else that's created this thing on the heart, right? So I think that that's usually how the EKG for me is always helpful is screening in and out primary cardiac arrhythmia versus the arrhythmia secondary to something else. We have to go looking. So I'm actually just pulling it up now. Um,
Yeah, so the first one that I sent you was the one that they got in the ED, and then the second one is a comparison from 2022.
so Andrew, I'm
I'm
not
still
seeing P
figuring out
waves.
I'm figuring out my technology over here.
Okay.
Okay. All right. Yeah, yeah. Okay. So I found the second one. Yeah, the second one just like grossly looks much more normal. Normal sinus rhythm. There's a P
Yes,
wave going
yes.
every QRS, and there's nothing kind of too interesting about this. Okay, let me look at the other one. You said you didn't see any P waves on this one, right?
I'm not sure I do. I mean, if anything, I might see a retrograde. Actually, I still might see a retrograde P. But I don't know that I'm seeing one beforehand.
Yeah, yeah. And I would say the QRS complexes are they're narrow and they're regular. Like
Right.
they're behaving on their own terms. So if there are P waves somewhere that we're not seeing because they're too small to see, they're behaving on their own terms. So I wonder if this makes us worry that this is complete heart block that we're missing
Certainly,
or
yeah,
or
certainly seems that way.
and then wait, let me see. The T waves, I'm just like looking at the T waves in V2 and V3. They look kind of pointy, not super pointy elsewhere. I'm just thinking of like, we're talking about what can cause kind of these Brady arrhythmia issues. We like to run to the electrolytes, make sure they're not hyperkalemic, causing progressive heart block and eventually that sine wave pattern. Any other big K abnormalities can kind of lead to badness. But no, the other thing I'm looking for, Mike, is like signs of ischemia too that could have kind
Hmm.
of led to this. And I already lost the image, so I'm gonna pause and pull it back up. What about you, Mike? What else is on your mind?
Yeah, I agree that the lights are always the first thing to think about. That's just right. That's the consequence of deranged electrolytes. Oftentimes, is the cardiac arrhythmias. So that's certainly something we just have to see pretty much in anyone. Ischemia, of course, right? Particularly if it involves the SA node, AV node, those areas. You can if you knock them out. This doesn't sound like what's going on because she doesn't have symptoms that would be suggestive of that. Beta blockers, severe, toxicity, that kind of brash syndrome, um, vagal tone, things like urinary retention, constipation, but that would be pretty profound for this. And, you know, when you don't see the P waves and you think this is complete heart block, then I do start to worry about things that are more primary cardiac. The other things can certainly do it, but it's just the thing that I also am thinking about kind of equally so. And so I think also on exam, looking for signs of heart failure, looking for, those sort of things as well, just to see, is the heart functioning appropriately? Echo as well is often helpful to start. But yeah, I mean, we definitely need to see the lights and we need to see what medications they're on. And I guess I say TSH again. And yeah, I think those are the things that I would start with. And then that posterior headache, I did not forget about. But I think I'm gonna wait for a little bit more information before coming back to that for now. I'm gonna put a pin in the posterior headache, but
Yeah,
keep it in on the radar.
yeah, I mean, I would just going back to like the scan mnemonic, Mike, like just bare bones, like CT head looking for large intracranial event could certainly capture something causing acute high ICP leading to this by virtue of high vagal tone. So that does have me a little worried if we don't find anything on the med list. And I don't see any signs of ischemia on the ECG after looking at it a little bit more. I guess the one thing before I pass it back to Nick, I'm a little kind of perplexed by is because we didn't really put our money down. Are we looking at complete heart block and we just can't appreciate the P waves, or is this a ventricular escape rhythm? I am a little struck by the response to atropine because my understanding is if this is high grade AV block, atropine basically poisons the vagus nerve and kind of dampens down the parasympathetic tone on the heart. So if your issue is high grade AV block, or it's at the level of the AV node, it has nothing to do with high parasympathetic tone to the heart. That shouldn't respond to atropine. So I think that's actually a point against that we're missing like P waves. I think probably this is uh, I guess sinus Brady, we're not seeing the peewees or ventricular escape, but yeah, certainly when you bring up that this could be a high vagal tone issue like urinary retention, constipation, that response to the atropine actually does kind of support um, very high parasympathetic tone, and then you're just kind of shutting that off with the atropine. So very interesting. I'm curious, Nick, how you read that. Clearly, we need to brush up on our EKGs a little bit. What did you think?
Yeah, excellent discussion. And I will say a lot of this is chart review. I know I've not met this patient, but I can tell you what the read was and kind of after knowing what the cardiologist read was, it was basically it was a junctional rhythm. So they were saying that they did not see P waves and that was a junctional rhythm. Um, Atropine was so the last thing that we did, we gave atropine, heart rate got up into the 40s, dipped down to the 30s, and again, an atropine was given. Um, Down in the ED, there was concern for complete heart block on tele, but I don't see any strip of this. I don't see any other like data that is doing this or data that is supporting this. But needless to say, the emergency department consulted cardiology. They started a dopamine drip that was on for about 15 minutes, and she converted to normal sinus rhythm. Um, I can certainly send you that EKG, or you can take my word that it did end up being normal sinus rhythm after about 15 minutes. They shut that off, and she was kind of back to more or less her baseline. She got a bunch of scans, and there was overall some chronic findings, but nothing new. So they did a CT of the head for the posterior headache. Did not see any evidence of a stroke. They got an angiogram study, and there was a PCOM, posterior communicating artery aneurysm that was stable. They talked to neurosurgery and they said there was no intervention at this time, follow-up outpatient. Again, they saw some severe left vertebral artery narrowing that was again noted on past scans that neurosurgery said to follow up outpatient. Did not think was contributing to her current picture. She did get a scan of her belly, which showed right kidney atrophy secondary to renal stenosis, a new 1.7 centimeter hyper-enhancing liver lesion, um, and a normal CTPE and a normal chest X-ray. It's a lot of data. I can certainly send you some of these scans. Oh, and the last thing was she did get an echo, and I can give you that read. Um, Basically, suboptimal study. Systolic function is hyperdynamic. So this was after she had received some her dopamine drip. This wasn't while she was acutely bradycardic. EF at around 65%. Diastolic function cannot be assessed due to severe mitral annular calcification. Um, Right ventricle is normal. Mitral valve said the annular calcification, no regurg, mild mitral valve stenosis, no aortic revalve, valve regurg, mild aortic valve stenosis. And that is the end of the second aliquot.
Ooh,
Ooh.
well, we had the same reaction, Mike.
That's
I'll, I want to correct myself really quick, Mike, before I let you speak. I said that the other option for the rhythm is ventricular escape. That was a mistake because it wasn't wide complex. That Nick told us it was junctional and it's narrow. Clearly, I need to brush up on my escape patterns. But Mike, I'll pass it to you and ponder because I'm honestly not sure what problem we're trying to solve. I think it is bradycardia, but in the context of these weird findings, I'm not quite sure how to approach it yet.
Nick, I just want to clarify. So she was given a dopamine drip, and pretty quickly she converted a normal sinus rhythm. Her mental status also returned to baseline as well.
Yeah, correct.
Okay.
Yep.
So by fixing the heart rate and the rhythm, we also fixed her altered mental status. And so that suggests that it was the heart itself and kind of a rarer case, right, where you see truly the profound bradycardia is responsible for, I imagine, just hypotension with the MAPS less than 65. She didn't perfuse your brain well. She has all this stenosis in her posterior circulation, so she probably got a posterior headache because she was, hypoperfusing relatively the back of her brain. So I think now the problem to solve is why did she have uh, heart block or disjunctional escape rhythm with, no P waves, it seems. And, what's interesting now is that we have a lot of negative data, but we do have this thing that lit up in the liver. Um, I don't know if that's a red herring. People get old enough, you scam enough people, you'll find things in the liver that mean nothing. But this is a diagnostic atypia case, so I have to think that it is. That was hyper enhancing on a contrasted study, or it was a non-con.
Correct. And I believe, let me double check here and pull her note up. It looks like it was a contrasted CTAP.
Okay, okay, so the liver lit up on that study. Yeah, so now I'm trying to think about things that can cause, bradycardia and liver lesions. And it starts to invoke more of a, systemic process, right? Something that's in the heart and the liver. You really have to have something that connects all of it. Um, if I remove the liver again, just thinking about base rate for, junctional escape, I suppose, and Brady complete heart block. I mean, one of the things is just as a patient gets old enough, she's 82, she could get some fibrosis of her conduction system. That's just age related. We talked already about hypothyroidism as a cause, med overdose, all of the parasympathetic things, which seem to not be the case. We're not hearing about urinary large bladder or lots of stool on the CT. We already ruled out and exonerated ICP, I'm pretty sure. And so then, other things, right? So Lyme disease is really common, unfortunately, in York, Pennsylvania now, as well as up in Connecticut. So, that does cause complete heart block. How that would give you a liver lesion, I'm not sure, although Andrew maybe could find a way to get there. And, something there's something valvular that we're hearing about. So I don't think that she has endocarditis that, created some sort of abscess near the nodes and then also created a septic emboli to the liver. I'm not hearing that there's anything on the valves that could explain that. So I think I've spun my wheels long enough, Andrew. I'm gonna take it over to you. But I guess we still need some labs too, right? We still need the basic lab stuff, but I'm guessing that there's maybe something in the labs, but maybe not in the basic labs. We'll see. We'll see what Nick has to say. But Andrew, other thoughts on
And
your end?
Mike, did anything stick out on the valves for you? I was just I think I got a little lost in the echo. Nick, was there something there that was kind of markedly abnormal or a little funny just before I?
I think
There's
it
just
was
a mitral
just and I can
stenosis.
send you, yeah, it was just the mitral
Okay.
stenosis and the mitral
Okay.
annular calcifications. And
Okay,
I sent you
Got it.
the echo read that I was just kind of reading
and
Got
over.
it.
very mild, right? Very mild, not severe stenosis.
So mild, correct, mild mitral valve stenosis and mild aortic valve stenosis.
Got it. Okay. Thanks so much, Nick.
Yeah, of
Yeah,
course.
yeah, no, I'm just trying to think like what are the next kind of set of data we would want to kind of make the most progress? And I feel like we have some sense of the patient's past medical history. Like I heard like a lot of cardiovascular risk factors, and the laryngectomy was for a cancer. Was that right, Nick?
Correct. Yep.
Okay. Yeah, yeah. So beyond that though, I don't think we've heard too much about kind of what their life has been like at home and kind of have they had any sort of subacute or chronic symptoms that could be giving us clues to kind of what we're seeing at the forefront here? It sounds like they kind of came in crashing with symptomatic bradycardia, and I just feel like it'd be helpful to know kind of their experience at home and see if that gives us any clues. And why I say that is, once we've kind of ruled out all of those very easily correctable causes of bradycardia you already went through, on the mnemonic V-Lido for bradycardia, an I after ischemia is infiltrative diseases. And yeah, when you see things kind of hyper enhancing the liver, suggesting something vascular, and there's this idea, okay, well, what are we left with for bradycardia? Well, something could be infiltrating the heart too. What can do that? I think broadly speaking, for infiltrative diseases, infections can do this. The notorious ones are disseminated granulomatous infections like TB. Autoimmune diseases like sarcoidosis can do this, IgG4 related disease. You can think of the deposition diseases like amyloidosis, like AL amyloid, classically causes pretty high grade AV blocks, but I don't think of it causing like focal liver lesions. And then cancers, and you can organize cancers by kind of the subtype of cell that is invading. So for lymphoproliferative disorders, you have lymphomas, you have Hodgkin's lymphoma, but a huge list of non-Hodgkin lymphomas that all behave very differently. Plasma cells can infiltrate. You can think of Waldenstrom's disease. Histiocytes can infiltrate. I won't go into that right now. Basically, that's kind of the approach you're taking. But, each of those entities have kind of predilections for organs. So I think just kind of taking stock of what's going on with the patient's body in terms of their symptoms and kind of what we've seen so far may be the most productive next step beyond making an assumption the liver lesion is kind of the culprit lesion and we just go for tissue there, which I think is a very big leap to make. I'm just going to say I agree with you, Mike, like taking a step back and like kind of dissecting the case without that is important. But if we're really left empty-handed, then perhaps we can think about it. But yeah, Nick, do you have any like backstory on the patient, or you keep just you've thought through how to present this. So what happened
Give
next?
you a little bit to nibble. So I will say there was needy triage nurse note saying that husband saw her. She was at her normal baseline that morning that she came to the ED. He went out to breakfast with his friends. He came back, and all of a sudden he felt that she was off and that she was kind of incoherent. That's when he checked his blood sugar, noticed that it was okay, and that's when he called EMS. So. Um, as of, a few hours before presentation, she seemed to be at her baseline, which other than a trach is a kind of relatively functional for an 83-year-old. But Mike, you wanted labs. We're going to give you some labs. So her CMP is significant for a CO2 of 16, an ion gap of 15, a glucose of 227, potassium of 6.1, a creatinine of 1.3, which is right about the patient's baseline, mag of 2.5, a sodium of 136, normal AST and ALT. She did have a lactate of 3.4 initially, which downtrended to 1.6 upon recheck once she was in normal sinus rhythm. She had a white for her CBC, she had a white count of 8 with a normal differential. Hemoglobin of 9.3. Her baseline's right about 10 to 11. Her MCV is 103. Her tropes were 5 times 2. Um, Normal INR at 1.1. PTT that was within normal limits. Her B Nancy P was 553. We don't have any priors to go off of. Her TSH was 92. Her free T4 is 0.7 on our assay. The normal is between 0.6 and 1.6. Her free T3 is 2.4 on our assay. Our normal is 2.5 to 3.9, so just a little bit low. Um, she had a UA with a little bit of bacteria, no leukocyte esterase, one white blood cell, 4 red blood cells. She was symptomatic, so they gave her a dose of IV ceftriaxone in the ED, and I will leave you guys there.
Okay, so I guess it's hard to ignore a TSH that's quite high with a, I believe, low T4, right? We had
T4 was normal,
was
so T4 was
normal. T4 was
0.7.
normal. Okay. All right. Well, it's a little bit. I mean, I usually don't see TSHs that high for euthyroid, euthyroid sick syndrome. And I also don't know what would be making it sick. But it's there. I don't know if that's a red herring. It doesn't really explain a lot of her presentation. It doesn't, and way I can't think, it doesn't explain the liver lesion. Certainly, hypothyroidism will lead to bradycardia. I mean, it's classic, and that in its isolation could explain it, but history is not really suggestive of hypothyroidism, right? It really should be kind of this insidious, slow process. And then also the T4 being normal just doesn't seem like you could, that doesn't just make sense for this degree of profound bradycardia. So then I sort of am then wondering, when we're looking at some other things, she is hyperkalemic. I've never seen potassium of 6.1 do this. Doesn't mean it can't, but that's something. I think the lactate can be explained by the hypotension when she came in, and she has a bit of a gap, anion gap, and so she has a anion gap metabolic acidosis, which I think that creates its own differential, right? And so um, I guess is there any the lactate could explain it, although it wasn't that high, and I guess beta hydroxybutyrate would be helpful just to, rule out ketoacidosis. But again, these are sort of things that I'm chasing labs, but I'm sort of missing the big picture, I feel, as I chase each of these. Um, so I'm gonna pause there. I just sort of digested the labs, I guess, Andrew. I didn't actually add much to the conversation in terms of things I think are going on. Um, interested to hear your thoughts, though.
Yeah, to be honest, I don't have too much more more to say than you. I feel like in real life, since it's quote resolved after the dopamine drip and things are better, I probably would have patted myself on the back and been stumped at this point. I was just thinking back about the liver lesion and thinking of like reasons we can disconnect it. And I remember that hemangiomas are very, very common, particularly in women. So I'm starting to distance myself a little bit more from that. But we still haven't gotten the medications, if I remember correctly, Mike. So certainly want to run that still. And yeah, I agree with your assessment, though, that I feel like we should be seeing a severely depressed free T4 to cause symptomatic bradycardia in this way. Nick, how did they do after that? We can give kind of the diagnostic test of time and kind of see how they do, since that's probably what I would have done in real life.
Yeah, absolutely. So, just I don't have her full medications here, but to note, she was on metoprolol tartrate 50 twice daily. She was on levothyroxine 112, aspirin 81, um, I believe a statin, amlodipine and losartan. So those were her medications. Um, so, cardiology was saying that, once they were consulted, cardiology was saying that the TSH was likely the cause for her bradycardia and needs to be addressed urgently. And they called our family medicine team for admission. So we admitted her, put her on telemetry. Um, she was normal sinus rhythm for 24 hours, and was basically feeling kind of herself. Um, Other labs that you guys might be interested in, we checked a cortisol. It was 25.7, and then we checked one in the AM, and it was 14.8, both of which are within normal limits and not low. Her TSH downtrended from 92 to 42.3, with a total T4 of 6.4, which is um, which is in the normal limits in our assay. Um, Patient was then asymptomatic for 24 hours, and after cardiology was signing off, it was felt that she was okay to discharge. Um, I will say before that, endocrine was consulted and basically said to kind of follow up outpatient, and that there was nothing really to do with a downtrending TSH. It turns out that the patient was taking her PO levothyroxine with food. So that is the end of this sort of aliquots.
Again, we have information that is hard to reconcile with what happened here. So really, the presentation in no way fits mixed edema coma or severe hypothyroidism, right? Because this was something that started relatively acutely. I mean, within one day, and then resolved entirely, essentially just with getting her back into normal sinus rhythm, right? I mean, we fixed her bradycardia and we fixed her blood pressure, we fixed her mental status. TSH is whatever it is, but the T4 was normal, and this illness script is not in any way fitting, severe hypothyroidism. So I can see why it went down that path, particularly in the absence of any other explanation. But it's hard for this case to really be that straightforward. I agree with Andrew that it sort of would have been a tincture of time, and then scratch your head as you're writing the discharge summary, and maybe this, gets figured out outpatient. If I put myself in the shoes of someone seeing her in clinic, I think it's going to have to do with has any of this come back or has anything changed since she was last in? Maybe this is something I need to read about, and this is a way that hypothyroidism can present early on, and that's totally fair. But I don't know. I feel like there's definitely something else going on here. I'm thinking about Andrew, times that TSH is a you know, red herring or a marker of something else going on. But again, I can't really reconcile that either. Yeah, I mean, I'm pretty stumped. I'll be honest here of what to do next. And the TSH downtrending by almost 50% in just like 2 days is also kind of strange. I mean, it's just a really fast response. So yeah, I mean, I guess the other thing would just be, and it doesn't sound like that's the case here, but anyone who has medications that in overdose have the potential to cause the syndrome you're seeing, just getting a really good understanding of their current mental health state, um, right? Making sure that this was not an overdose, intentional or unintentional. Because if you told me that she took her entire 90-day supply of beta blocker, right, then you basically have, right, that would explain this. Although it should linger. That being said, I think it was metope tartrate, so it wouldn't linger that long. Maybe within 2 days, it's out of your system. So just rambling again. So Andrew, I'm wondering your thoughts. I don't even know what other tests to order. I mean, I guess I don't know. Maybe I'll ask for a Lyme disease, Lyme titers. I mean, who knows? I'm just throwing darts at the dartboard. This doesn't fit that illness script either.
Yeah, no, I'd send you the antibody test for that since we're stumped. And yeah, no, I think what Nick told us is if they were taking it with the food, they were taking I should be more specific. If she was taking the levothyroxine with her food, she isn't absorbing it properly, so that sets you up to be in a hypothyroid state, which she was like tipping into based off of the labs. But I think for it to cause symptomatic bradycardia, the free T4 would have to have been pretty low, and it sounds like it was like borderline if anything. But I'm open to being wrong here and like hearing from endocrino that this is actually what you see in like the very early stages of this. Because she wasn't like myxedema coma like you're saying. She was just like becoming Brady and it was causing some issues. But then she corrected really quickly too. So yeah, no, I'm curious, Nick, how she did in clinic follow-up, presumably when you saw her.
Yeah, so I will say this is the last aliquot followed by some teaching, and this is still kind of an active, ongoing thing. So we don't have everything completely figured out, but there's some more information here that I think is interesting. Um, so I will start by that the hyper-enhancing liver lesion was recommended for outpatient follow-up. There was not anything acute that they thought was going on there. Um, so she was discharged. 2 days later, she goes to the ED with tachycardia to the 120s. She doesn't have any palpitations, lightheadedness, blood loss, chest pain, or shortness of breath. It is just something I think that she found on her like Apple Watch. Um, the labs were within normal limits. A sodium of 132 was the only significant finding. Her delta tropes were negative. They did a respiratory viral panel, which was negative. Um, they did a new EKG, which I will send to you guys. Um, and that was really her ED visits. For the listeners out there, basically the EKG is sinus tachycardia. Looks kind of similar to her one from 2022, just sped up a little bit. So they just kind of thought that was a little bit weird. Obviously, patient and her husband are frustrated. Um, She was seen by one of my fellow attendings a couple days later, decided to hold the beta blocker, followed up with cardiology 8 days later, where they restarted the BP meds, including the metoprolol. 9 days later, so a day after her cardiology appointment, she went to the ED again, bradycardic to the 20s and 30s with systolics in the 70s and unresponsive. She was given 10 mics of epi by EMS and externally paced. Her TSH was again above 92. She was given an IV levothyroxine loading dose, and her TSH is now 18 with normal free T3 and T4. Cardiology consult as of this morning. No pacemaker yet until endocrine recommendations.
Wow. Wow. Mike, I have a theory, but I'm open to being completely wrong. Wait, so in the timeline is this. So when they restarted the metoprolol, this is when she
Mhm.
became okay, she became bradycardia again. And the TSH was up again. The TSH was
TSH
up
was
again.
92. Yep.
Okay. Okay. Yeah, is this someone who's just like teetering on kind of this like severely hypothyroid state and they just have that extra punch with the metoprolol that's causing this, Mike? So it's not just that, but there's something else going on. That's my thought, but I got nothing else.
Yeah, I'm wondering the same if this is sort of a multiple hit on an underlying vulnerable host, right? So which we see frequently. So and she's 82. She could have something like sick sinus syndrome, degeneration of the AV node, right? That just occurs as we get older, unfortunately, sometimes, right? You get unlucky. And then, right, she has a beta blocker on board and is sort of flirting with hypothyroidism back and forth, and just the metope again kind of kicks her over. I think that's what I would try to sound smart saying on rounds, but I don't know that I have anything more eloquent than that, which I think is exactly where your brain is as well, Andrew. Really, what you need to see is you need to see her well with a TSH normal. That would I suppose that would much more strongly support that case, right? If you can keep her euthyroid, and then she never has these symptoms again when she's euthyroid, and only has them when she's sort of teetering on hypothyroid. Then I suppose that would be your answer. I do wonder if just given enough time, though, she'll eventually need a pacemaker for something underlying, fibrosis degeneration with age. Those are my thoughts, Andrew. I don't know if you have anything else. It sounds like we're going to get some teaching from Nick, which I'm uh, in need of and excited to hear.
Teach us, Nick.
Yeah, so there's no big gotcha or no big like very satisfying diagnosis at this time, but I think it there's a lot of good teaching points that I learned throughout this. So the first one that I was so I took this call on a Sunday and I was not going back on Monday. So essentially I was signing out to the next attending, and one of the thoughts is when the cardiology says to treat this hypothyroidism urgently. Is, what are the indications for levothyroxine? And really, there's not too many. Like you were saying, mixed edema coma, that's the big one, right? And then severe GI malabsorption, MPO status, or refractory hypotension are the indications. So, in this patient who was initially a TSH, over 90, and then kind of corrected to normal sinus rhythm and was mentating okay, I consulted my father and I was like, "Would you do levothyroxine in this case and or IV?" And in the setting of kind of normal mentation and then maintain a sinus rhythm, we decided not to in that first case. Now, when she came back to the hospital and was hypotensive and altered, they gave some levothyroxine and some IV. But the other thing is that PO levothyroxine should be taken first thing in the morning, 30 to 60 minutes before breakfast on an empty stomach, and 4 hours apart from drugs that significantly affect absorption, including iron and calcium supplementation. So it's not uncommon that someone is iron deficient and also needing TSH. And that can be kind of a tricky thing to navigate in the outpatient setting, especially because iron absorption is better at certain times of the day as well. Um, typically in the morning. So, um, and then one thing that I learned, which I did not know, is that minor alterations in the bioavailability of T4 can have significant alterations of TSH, and TSH is a more sensitive marker of thyroid hormone action than T4. Um, when endocrinology was consulted, they confirmed that the bradycardia can be secondary to an elevated TSH in the setting of a normal free T4, which I had never heard of, but looking it up, the mechanism of action is actually pretty fascinating. So there's TSH-mediated cardiac remodeling and auto, autonomic regulation, um, rather than an actual deficiency in the thyroid hormone. So elevated TSH can directly modulate cardiac potassium repolarization channels, lengthening action potentials, and slowing the heart rate independent of T4 and T3 levels. Then the elevated TSH also kind of modulates our nervous system towards more of a parasympathetic dominance. And there's actually been clinical studies looking at patients with subclinical hypothyroidism that have slower heart rates during exercise and at baseline than euthyroid controls. So TSH independent of T4 and T3 levels can have bradycardic effects, which is something I didn't know. And then I have my last teaching point is something that I was kind of thinking of as well, Mike, that you brought up, is tachybrady or sick sinus syndrome, that occurs with fibrosis or degeneration of the SA node. So basically, the tachycardia are more propensity for ectopic atrial rhythms that can take over as the dominant rhythm and suppress SA node activity during episodes of bradycardia. A higher propensity of ectopic atrial rhythms in an already fibrotic RA. We did get her echo. Obviously, she did have some calcifications. She has some narrowing in other parts of other vessels. It's not impossible to think that she has some fibrosis also of her heart as well. And then really the management is to stop meds. So the beta blocker is probably off the table. And then after all of that is kind of taken care of, then you think about a pacemaker. So that is my teaching. The thyroid thing was completely new to me. I don't know what your guys' thoughts are on that.
Yeah,
Wow.
no, I think that that's the case. That teaching point I think is the case. I didn't put as much credit on that, and I think it's exactly what you said that the TSH has effects independent of T4. That is, I don't know about you, Andrew. That's totally new knowledge to me entirely, and changes the way fundamentally I think about this. I just always thought about that as a marker. I didn't think about it as an actual, um, as an etiology of the consequences. I just thought of it as a marker for the T4, which is yeah, just really really fascinating. I love that like exercise, lower heart rate during exercise for subclinical hypothyroidism. That's just fascinating. Andrew, thoughts? I really cool case.
Yeah, so cool. I'm struck by the quote from House, it's never lupus. I feel like it's never the thyroid. Unless if it's like myxedema coma, it's like never the thyroid. So it's really cool to see it present in a very sneaky way because no doubt we're gonna run into this again and someday. Because this is like pretty sneaky. Because she kind of needed that kind of like second hit to tip her over the edge, like we already said over and over again. And I'm just struck also by that atropine response actually did play out in terms of the final diagnosis and being a strong clue because we were talking about, or I'll say I was talking about infiltrative diseases, all this stuff. None of this stuff would have responded to atropine if it was causing AV block by virtue of infiltration of that system. That stuff doesn't respond to atropine. This is an etiology where it was just a high parasympathetic tone and you just shut it off with the atropine and it got better. And that very rarely happens. So I think when it does happen, you should use it as a powerful clue to what could be going on. And yeah, I'm going to start taking the TSH a little bit more seriously. Very cool case, Dick. I'm really glad you brought this.
Yeah, thank you. That was fantastic.
Yeah, I'm happy to be a part of it, and I learned something new, and I had no idea either. So glad I could bring it to you guys.
Awesome. Really appreciate it.
Yeah.
Thanks everyone, and we'll see you next episode.
Yeah. See you guys.
This has been Diagnostic Atypia with doctors Andrew Sanchez and Mike Arcieri. The show is produced by us with the help of Podcastle. Our intro-outro comes from the album To the Surface by pianist Lawrence Fields. If you enjoyed this show, consider subscribing and sharing our episodes with others. If you have your own atypical diagnostic journey to share, please reach out to us dx.atypia@gmail.com. We'd love to discuss it with you, and we welcome medical students, residents, and even seasoned attendings. Happy zebra hunting. We'll see you next week.